Right, so this is what we're going to talk about, advanced in total knee replacement. So, firstly we'll start with the anatomy of the knee. There's essentially three parts to the knee. There's the medial compartment, which is on the inside, number one. There's the lateral compartment, which is the outside part. And then the patellofemoral compartment, which is where the kneecap is at the front of the knee that rides over the front of the thigh bone. And the patellofemoral part of your knee is important when going down stairs and going down inclines. And in the normal knee, the bones are covered with cartilage, which allow the bones to glide smoothly over each other. And as our arthritis progresses, the cartilage lining gets worn away, a bit like the brake pads in your car, and the gliding surfaces get disrupted and uneven and rough, and that causes grinding and crunching and cracking and feeling of instability, and also the underlying bone is exposed, and that's what causes the pain. And the most common form of arthritis is wear and tear or osteoarthritis, and that's where the lining becomes pitted and eroded and uneven, and the cartilage falls off, and where's our pointer? It makes its way to the edge of the bone. So this diagram here, I don't know if everyone see the pointer? That forms what's called a bone spur, or a medical term for it is an osteophyte. And they find their way to the edge of the joint. The bone spur itself is not the problem, it's the result of the problem, which is the cartilage falling off the bone. And in the process of osteoarthritis, activities of daily living become limited by the pain. And most of us, as we get older, over the age of 45, do have a little bit of arthritis, and it just so happens that women are more affected by than men. So the main symptoms of osteoarthritis is pain, that reduces movement. It's associated with stiffness and swelling, and that's all part of inflammation. And they limit daily activities, walking, dressing, ability to get in and out of the car, do housework, and sleep disturbance as well. So the main causes are wear and tear, the passage of time as we get older. Often there's injuries in the past from sports. Age is something none of us can do anything about. We can't slow down the passage of time. Obesity is something that we can deal with, but again, it's easier to say, oh, I'll go and lose some weight, than actually go and lose some weight. And then sometimes a deformity in a bone can cause uneven wear and lead to premature arthritis. And then there's work-related activities or accidents which can occur at work. So, with everyone living longer and there being baby boomers and people getting heavier over time, there's three major factors as to why knee replacement is becoming a much commoner procedure, and the projected figures is that there's going to be a 5-fold increase in the number of knee replacements in the next 10 years, which is quite a lot really. So there's plenty of work out there for us orthopaedic surgeons. So there are ways to reduce your risk of needing a knee replacement, and some of those are lifestyle modifications, so increasing your activity, staying fit and active. Weight control has been shown to be one of the major factors. That's why I put it in big letters with exclamation marks, because trying to maintain a decent weight is very important. Exercise is also important, but has been shown to be less important than reducing weight. Bracing is an option. Anti-inflammatory medication, simple over-the-counter ones to start with, such as ibuprofen or Advil. And then there's also Aleve, which is naproxen. And then, so those are things that people can do prior to seeing the doctor. But then other examples of management include steroid injections, which can be done either by the primary care providers or us as the hospital doctors. And then there's other alternative injections which aren't steroid, called hyaluronic acid derivatives. And those act as shock absorbers. They're often a course of 3 injections, and it's a type of gel or lubricant for the knee. So, as just stated, research has shown that exercise is one of the best treatments, but a healthy diet can help weight loss, and often we try and recommend going to see a dietitian before considering any other treatment, because even losing 10 pounds can make a difference and reduce pain. So medication, there's Tylenol is not such a good anti-inflammatory, but it's a very mild painkiller with low risk. As long as you don't take too many of them, it's a fairly safe medication. And then there's anti-inflammatories, which have slightly increased risks of, they can cause stomach heartburn, they can increase blood pressure, and they can interact more so with other medications. So some people aren't eligible to have anti-inflammatories. And then we go on to the nasty ones, the opioids, which are a lot stronger, but in the right people they are effective. And then there's the injections that we just mentioned, and which are both steroid and these hyaluronic acid derivatives. So now we've dealt with the easy stuff. Now we go on to the scary stuff, which are the surgical solutions. So depending on the pattern of the arthritis, some people are candidates for partial knee replacements, but it's only really if it affects principally the inner side of your knee, that medial compartment. We can do them on people who have arthritis in the outer part of the knee, but they haven't shown the long-term results that we would like of the inner partial knee replacement, or even the patellofemoral joint, the kneecap joint. The benefit of a partial knee replacement for those who are candidates are that it feels more like a normal knee, and the recovery is that bit quicker. So if somebody has arthritis in their patellofemoral joint and the medial compartment, there are a couple of companies that make these deuce or bicompartmental, and of the 3 types, the uni or partial, the total, this is the least common of all 3, but it is a potential option. And now we go on to the even more scary part, which is the total knee replacement. And so ideally what you as patients want is improved range of motion, a stable knee, a good fit that allows you to function normally, and you want it to last a long time, so you want it to be durable. What we want is patient satisfaction, predictable outcomes that are reproducible, and minimal complications. Unfortunately, we all get complications. We try to minimize those, and we want satisfied customers. Now, compared to hip replacements, knee replacements, there's about a 17% complaint rate from patients. So almost 1 in 5 patients are unhappy one way or another with their knee replacement, which is unfortunate. So this is one of the reasons why the companies have looked into where things are going wrong and how we can improve. So this emphasises that 1 in 5 patients are not happy, which is quite a fair percentage really. And these are the main reasons. This is quite a busy slide, but it's thought that one of the dissatisfactions is that the legs aren't aligned properly, so you get uneven wear, a bit like the tyres in your car. If they're not aligned properly, then they wear out quickly. And part of that may be due to implant engineering, and that leads to early failure. If something doesn't fit properly, that leads to improper alignment, and supposedly that's that occurs in 10 to 15% of patients. And then reduced function. If the patient has stiffness, reduced range of movement and instability, they're also dissatisfied. So in general, there's three main categories: ongoing pain, early failure and reduced function. So one of the difficulties we face is that all patients are different shapes and sizes, and so deformities are very different, and the wear pattern is different. As I said, everyone's a different shape or size, and each company produces a certain prosthesis with a range of sizes that we can use, maybe 5 or different sizes, but even so, we have to, within a given size range, we sometimes have to choose, for example, between a size 4 and a size 5, and it's not a precise fit. So this company Conformis, and I should have declared at the beginning that I have I don't get any kickback from them, but they've come out with a system where, which we're going to talk about now, where a patient has their own custom-made implant. So it's a patient-specific fit, which allows us to position the implants specifically. This term, mechanical axis alignment, makes sure that the knee is directly in line with the hip joint above and the ankle joint below. So in theory, the wear of the implant should be much improved. Because it's custom fit for the patient, we're only removing a certain amount of bone in order to fit the parts on. And if everything is aligned properly, it should reduce the wear. And also the way that they have produced what we use, called the cutting blocks or the cutting jigs. Everything is patient specific, so that it allows them to deliver everything in essentially a shoebox, and we'll come on to that as well. So total knee replacement in general involves making a few cuts at the end of the thigh bone. We cut away the worn area, and we reshape it and make cuts around the bone. And we'll be passing around some models. We might be able to start that very shortly. And the models show the cuts that we make to accommodate the new spare parts. And then there are different types. Depending on ligaments, we can preserve what's called the posterior cruciate ligament, or we can sacrifice it. So if a patient has, for example, a knee that they can't straighten fully, that implies that both of their ligaments in the middle of the knee are tight, and so we take them both away and replace them. So there are various options that we can make during the surgery. So this shows the metal cap to the end of the thigh bone, and as you can see, there are various cuts, 1, 2, 3, 4, 5, that we make to accommodate the new cap to the bone. Similarly, the top of the shin bone, there's all these bone spurs, and basically we make a flat cut with a keel, and that accommodates the tibial component. And we have to make sure that is also aligned with the rest of the leg. So this slide demonstrates the plate that goes on top of the shin bone, and then in between are plastic inserts. And again, there are different types of inserts that we can use of differing thicknesses, which allow us to balance the knee correctly. Now, the Conformis system, when we make those cuts, this demonstrates over the front of the thigh bone. In the traditional system, the prosthesis may leave exposed bone, which leads to more bleeding after the operation. Supposedly with this system, they know exactly the fit of the prosthesis, and so there's much less exposed bone. there's less bleeding after the surgery, so the recovery time is that bit quicker. So there are various steps involved, and the main step that involves the patient is having a CT scan. The CT scan is done here at the hospital with a special protocol, and all those images get sent to the company in Massachusetts, and then they have some computer whiz kids who work out the shape of the prosthesis, and then it's all made with 3D mapping and 3D printing the various cutting blocks. And the production process takes about 6 weeks. So tomorrow, if I see somebody who needs a knee replacement, we send them for a CT scan, which may be done next week, pending insurance approval. And then if it's the beginning of August, by the middle of September, we have all the parts are made, and they come in a shoebox. And this is the what the table looks like when everything is laid out, and we've got various parts. There are 1 or 2 metal bits, such as the handle that we hit with the hammer, and these are the actual implants. So it's a lot more compact and efficient. So it's made to measure, gives better alignment, it's less invasive, we're not putting that big rod up the femur. We have to make the incision the same size because we're still opening up to expose the bone. It's supposedly a shorter operating time, but at the end of the day, hopefully it's giving a longer lasting knee. It reduces the surgery time, there's less blood loss, hopefully a lower risk of clots because we're not putting that rod up the femur. It's a cheaper system because we're not sterilising all those metal trays. There's less time between operations because there's less to clean up afterwards, which allows us to do maybe more operations in a particular day. So the surgeons enjoy it because it's more efficient. The hospital likes it because it's a cheaper working model, and hopefully patients prefer it because it's less invasive and a faster return to recovery. It's not just what we do in surgery though, there are other aspects to the management of knee replacement, and certainly anaesthesia has played a big part in that, and that involves the pain management. Not only we start it before the operation but also during the operation and afterwards, and they use various techniques including injections into the thigh, which helps. And then there's new techniques with rehabilitation and post-operative recovery protocols, and so all of that has been shown to improve recovery, both length of stay in hospital, which used to be 1 or 2 weeks, now we're down to about 2 or 3 days, and people get up and walking the day of surgery. In some places they're doing this procedure as a day case, so you come in the morning, go home by the evening. We haven't started doing that as yet, but some people do go home the following day after surgery, but most are after 2 days and a few after 3 days. And as you can see by all these other specialities who are here today, and we'll introduce them all at the end, it involves doing a lot of screening beforehand to make sure people are fit for the anaesthetic. We even have the ability to have Matt or his colleagues to go to people's homes to determine whether or not they need any modification of railings or steps, or just moving furniture around the house to make things easier for when you go home. Talking about who's going to do the cooking when you get home, are you going to prepare meals in your freezer if you live alone, all those little things that do make a difference. The pain management we touched on. If people are already on strong painkillers for other reasons, we try and wean them down a little bit so that we can give adequate pain control afterwards. We talked about the improved surgical technique, but also when you're in the hospital, if you've got other medical issues such as diabetes, we involve the the much more clever doctors who control your blood sugars. If you've got lung problems, we get the lung doctors involved. The therapists, both physical and occupational therapists, get you up and moving very quickly afterwards. And another very important part of the team is our social work department, and we do have a guest here as well, and because we need to know about your home circumstances and what sort of environment you're going home to. You can go to a rehab facility afterwards. And then the last thing is nutritional support. Now, we talked briefly about obesity. It's been shown that people who are actually obese have poor nutrition, and they're also at risk of getting a higher risk of getting infection. So we get dietitians involved for that reason as well. So, would I recommend this to my mother-in-law who does have arthritic knees? And I probably would. Yes. That's not a picture of her, by the way. And then hopefully we do have a member of the surgical team here. Maybe she'll be able to have some input whether they like the system upstairs in the OR. As we talked about a few minutes ago, really we're still waiting for the long-term studies, but so far so good. And the new technology has to prove its merit. And it doesn't necessarily mean that because it's new and it's the latest technology that it's the best, but the reasoning behind all of this, it seems a reasonable way to go. And so far, this is what they've shown, that the length of stay is that bit quicker because the early recovery is that bit quicker. We're transfusing a lot less blood, which also reduces risks. Most people are going home, and a few are going to rehab facilities afterwards. And there's a lower risk of adverse events. OTS stands for off the shelf, by the way. So they've compared this new system Conformis with the off the shelf implants. The OR time is that bit quicker. We have to do less releases. The length of stay is that bit quicker. Overall faster recovery and less blood loss. So I'd like to introduce Mr. Carl Ribeiro, who's really one of our stars.
Well, I have to tell you, it was I'm 71, and this was my first surgery. I lucked out through life, and I'd never even been in surgery. And when he showed you the slides of the knees that were in really bad shape, the second one in, how it was starting to be bow-legged, well, both my knees were worse than that picture. So I basically, my knees came down and I was bone on bone and my kneecaps were all screwed up. So I was definitely eligible for this. It was I don't want to say it was a great experience, but it was awesome. I had both of my surgeries were done on Tuesday, and they sent me home from the hospital on Thursday. So it was just Tuesday. And quite frankly, when I came in to meet, I didn't know about any of this. All I was explained to me was that his assistant explained to me that these new procedures was, instead of buying off the shelf and making your knee and the surgeon doing whatever they need to do to make the whole thing fit, that it makes, basically it's custom, and that sounded good to me. When asked if I had any questions, if I had any issues after they explained it to me, I said, well, quite frankly, one of the things that I'm worried about is, am I going to have to use a bedpan? Am I going to be able to get up? And they said, no, that's not an issue. Now, I don't know if everybody will be eligible for it, but the two things that happen, besides the process, the hospital here is great. And in preparation for the surgery, they basically give you a shot right above the knee where the nerves come down and go on either side, and they basically numb it. And that numbing lasts for 24 to 36 hours. So the other thing that happens just before I went in for the surgery, they gave me a spinal. I was eligible to have a spinal. And from my perspective, I would recommend that. I've heard about the other types of putting you to sleep, and when you wake up, you're all groggy and stuff. With a spinal, after the operation, when I woke up and it was like you just wake up. No headaches, no nausea, nothing in your head. And because of this shot that they give you in your knee, I had no pain. I felt great. And they basically said, if you got to get up and go, we just want to be there in the room. They gave me a walker. I got out of bed and went to the John. It was like, I didn't know anything had happened at all. There was a patch over my knee, but I could move it. And my range of motion that he talks about, even after the first day, my range of motion was already past 90 degrees, almost up to 100 degrees, which means if you're, you can bend your knee like this or back and forth. And this is the one that was done in April. This is the one that was done 6 weeks ago, on June 13th. And the range of motion is right there. Now, I'm not going to tell you that there's absolutely no pain at all, and actually there isn't any real pain. There's a discomfort once in a while. I'm used to walking with a cane, and I've gotten used to that, and it helps the stability. I don't use a cane in the house. But when I'm out and about, I figured it just is a safety blanket for me. If you have any questions, I don't know if there's anything else I can talk to you about, but I'd be happy to answer any questions. I definitely recommend it. If you can have the spinal, go with the spinal. And the really nice thing, just beyond the fact that it's really cool, the hospital here is really nice. I mean, I've lived in the area for a while. I've never had to use the hospital, thank goodness. But they put you in the floor, the section. Everybody has got similar types of activities, so it isn't like the next person down in the hospital wing, the section you're in, is somebody that's sick or has a different issue. Everybody, they keep all the people that have had orthopedic surgery in the same area. It makes it easy, so all the nurses that work that section, they know primarily your issues, and they don't have to be a jack of all trades. They can be dedicated to that. They're very attentive, and it was really a great experience. So,
can I ask you a negative question? What was it like when the block wore off?
When the block wore off, because they were very pro pain management, there was some discomfort. But I want to use the word discomfort rather than pain. And it was like they always come in and say, what's your level of pain? And it's like, there were times I had to make it up. It's, I didn't feel, I was at a 2 or a 3. And I was afraid if I said I was at a 2 that they would say, oh, you're done. So I'd say 3 or 4 just to keep them, make sure that, but it wasn't bad at all. And, and I think it's because of the pain management that you do. My wife used to be, years ago, a surgical nurse, and she's talked about how different things have changed in the whole process. Again, years ago, you would come into the hospital for 2 or 3 days before you even had the operation, and then it would be a week or so afterwards. For me, I showed up, Tuesday morning, they tell you what time, and you go from there.